Hello, and welcome to Crohn's and Colitis Canada's Gutsy Learning Series event. This webinar is being offered in English with French live translation. To listen in French, please select the interpretation icon found in the webinar menu bar at the bottom of your screen. And if you have any technical problems, please try refreshing your website browser or relaunching the webinar. You can also chat with us using the Q&A box found in the webinar menu bar. This webinar is recorded and a link to the video will be sent to your email and posted to our website tomorrow evening. French subtitles for this video will be available the following week. And you can access all of our GLS videos at www.crohnsandcolitis.ca/GLS. Our Q&A period will be based on those questions that were asked ahead of time when you registered and those questions that are asked during the live broadcast. We will do our best to get to as many questions as we can. Please comment in the Q&A box found in the webinar menu bar to ask your question at any time. We cannot answer questions about specific medical situations. And now it is my pleasure to introduce Crohn's and Colitis Canada's Vice President of Research and Patient Programs, Dr. Kate Lee.
Thanks, Sarah. Good evening, everyone. Thank you for joining us tonight for our Gutsy Learning Series webinar. Before I introduce tonight's guest speaker, I'd like to start by sharing our promise, which is to improve the lives of children and adults with Crohn's disease and ulcerative colitis and to eventually find the cures. Whether it be a public-facing session such as our webinars or an internal company presentation, we normally include our promise slide to always ground us and remind us why we're here and to use this as a beacon for everything that we do. We run an array of programs to meet our promise, and since it's Mental Health Week in Canada, I want to remind those of you in the audience that we're here to support you. If you would like an IBD buddy, we can match you with a fellow IBDer. If you just want to listen and be part of a group, we have bi-weekly virtual peer support groups and local chapters. And we have people who you can speak to on the phone and via email. So we encourage you to reach out to us. One of our programs that has a lasting impact on the participants is our Camp Got to Go program. Pre-COVID-19 pandemic, the program was a one-week in-person camp experience in Alberta, Nova Scotia, and Ontario. In 2020, we shifted to a virtual camp experience. This year, we will be holding half-day camp sessions on consecutive weekdays in August. If you know someone who is between the ages of 9 and 17, please pass this opportunity on. It's a great way for them to meet others, make lasting friendships with children and youth from across Canada, join in on games, crafts, and other fun activities. For upcoming webinars, we have another Gutsy Learning Series webinar lined up this month on a very popular topic, diet and nutrition on May 18th. And our COVID-19 and IBD webinar series continues with the next one scheduled for May 27th. To register, please scan the barcode on your right or type in the URLs on your web browser. Without our volunteers and fundraising activities, we would not be able to deliver on our programs. Our largest signature fundraising event is just around the corner on June 6th, where people from across Canada will be joining us together as one to raise awareness and funds to support the IBD community and to find the cures. If you haven't registered yet or are new to Gutsy Walk, I encourage you to go to gutsywalk.ca to learn more and register. Tonight, we have two special guests who will be presenting on a pan-Canadian initiative, which Crohn's and Colitis Canada is part of, called the Imagine Network. Dr. Paul Moayyedi is the principal investigator of the Imagine Network, professor of medicine and past director of the Division of Gastroenterology at McMaster University. He's the Audrey Campbell Chair of Ulcerative Colitis Research and Assistant Dean of Research at McMaster University. Dr. Moayyedi has published 425 peer-reviewed articles and has been cited over 56,000 times. He is past co-editor and chief of the American Journal of Gastroenterology and currently joint coordinating editor of the Gut Cochrane Review Group. Last but not least, Dr. Moayyedi is co-author of our joint Canadian Association of Gastroenterology and Crohn's and Colitis Canada's position statement on biosimilars. Accompanying Dr. Moayyedi is Aida Fernandes, who is the executive director of Imagine SPOR. Aida has over 15 years of experience in research administration and strategic partnerships in the health charity sector. She is past VP of Research and Patient Programs at Crohn's and Colitis Canada, i.e. I'm the new Aida at Crohn's and Colitis Canada, and has also worked at Cystic Fibrosis Canada in several roles, including manager, chapter relations, director of volunteer and personnel resources, wow, and director of medical and scientific and community programs. Last, Aida has served on governing bodies in the voluntary health sector, including Health Partners Board of Directors, Health Charities Coalition of Canada Research Committee, Canadian Genetics Coalition, and CIHR's Institute of Infection and Immunity Institute Advisory Board. Welcome and thank you for joining us, Dr. Moayyedi and Aida.
Thank you, Kate, and thank you again for the invitation to this webinar. We're really excited to share some information about the Imagine Network, and I will talk a little bit about what the Imagine Network is, what we do, and then I'll pass it on to Dr. Moayyedi to give you more information about the research we're doing. So just in general, the Imagine Network, it's a research network. It's made up of 17 different hospitals, universities, and 75 researchers and over 30 patients across the country. We're focused on investigating what's the interaction between inflammation, microbiome, diet, and mental health in patients with inflammatory bowel disease and irritable bowel syndrome. So Imagine is one of 5 chronic disease networks that was funded by CIHR, and CIHR is the national government funding agency for health research. And it's one of their SPOR initiatives, and SPOR really stands for Strategy for Patient-Oriented Research. So we're one of 5 networks that were funded. There were other networks funded in the areas of diabetes, kidney disease, chronic pain, children with brain-based development disabilities. And so our area is obviously in the GI health area. I think what's special about Imagine is that as a patient-oriented research network, we do have over 30 patient partners that are closely integrated in all of our network activities. They're members of the governance structure. They participate in scientific working groups for all the different projects we're running, and they often even conduct research themselves. Sorry, I'm just trying to move the slide here, and I don't. There we go. Perfect. Okay, sorry about that. It's a little bit of a delay. So Imagine really brings together gastroenterologists, neuroscientists, psychiatrists, currently working in isolated silos, and brings them together in a network so that they can focus on the brain-gut connection, which means they're defining what's the two-way communication between the gastrointestinal tract and the central nervous system. And they're also investigating how changes in the gut microbiome may influence anxiety and depression associated with gastrointestinal disorders. The overall aim of Imagine is to identify the key mechanisms in this diet microbiome host relationship, and then test new therapies for treatment of IBD and IBS and their associated psychiatric disorders. Overall, the mission of the network is to transform the management of IBD and IBS and the associated mental health issues that are associated with these diseases. Next slide. Thank you. So the overall hypothesis I mentioned before, and it's summarized in this picture here, is that the Imagine Network is trying to again, understand that diet, microbiome, and inflammation interaction and how they impact IBD and IBS and the associated psychiatric disorders. Next slide. Okay, So obviously, the network is involved in research as its main activity, but beyond that, there are a number of other programs that are core to its nature. We're supporting patient engagement, knowledge translation, and capacity building. And so I'm just going to describe that a little bit more detail so you can understand what we're up to. Next slide. So in terms of patient engagement, obviously, as I mentioned before, we involve patients in all aspects of our research. Patients conduct some research. We've had them do qualitative research studies. We engage patients beyond just being a subject in a study. We use them to get advice, guidance in the research projects so that we're making research as relevant as possible. Finally, we're actually evaluating to see what is the impact of patient-engaged research on the overall outcomes of research. On the knowledge translation front, Imagine is helping influence health services policy. We've held a number of citizen panels and developed reports, policy reports that go to decision makers in the government on a number of important issues. For example, I think relevant to this community is we did a panel on how to reduce emergency room visits for patients with inflammatory bowel disease. We've more recently also held another panel and completed a report on how to improve health systems so that clinical services are optimized for patients. On the knowledge translation front, we're providing a number of scientific content that's been translated into more lay language so that it's more useful for patients. We're also supporting knowledge translation activities after the project is completed to make sure that the results that that research project had get into the hands of the people that need it the most. Also on the knowledge translation front, we're conducting some research to see whether or not our activities in this area are actually improving people's understanding of the work we're doing. On the capacity building front, really that refers to improving the research skills of the next generation of researchers and scientists and clinicians. So the Imagine Network is doing a couple of different things in this area. We're supporting educational outreach programs, such as a monthly webinar training series. So this allows trainees to get the best advice from senior investigators on how to improve their research studies. We're providing research training awards for undergraduate students and PhD students. And then we're fostering career development and mentorship by pairing up trainees and senior investigators. On the research front, which you're going to hear a little bit more about from Paul, obviously we're conducting a very large scale study, which is the main core of our network. But we're also supporting a number of other sub-studies that are really relevant to the theme that I spoke about earlier. So I'm just going to give you a brief overview of that in a few short slides. Next slide. So before I jump into the research, I just wanted to highlight some impacts that our network has had. So the network was launched back in 2016. We probably didn't really get off the ground until 2017. And since then, we've done a number of activities to increase awareness of the work we're doing, to share the research that our investigators are conducting. And so you have some infographics here that highlight some of these. And just to point out, we've held over 170 different research presentations. We've mentored over 134 research students. We've reached 315 trainees through our webinar series. And we've also done a few more public facing type activities, media interviews, podcasts, radio interviews, and been involved in social media, really to help spread the word of our research so that we can get more people involved in our research and share our research findings. Next slide, please. Great. So getting back to our research, the network is supporting studies in these particular areas. So we have microbiome, patient engagement, diet and the environment, health services, mental health, and sex and gender. And so next slide. So we have about 30 active sub-studies right now beyond our major main cohort study. And I've sort of listed them here underneath each of the different thematic areas. I just wanted to point out, in fact, a good majority of the research sub-studies that we are funding are focused primarily in IBD patients. There's some that we're looking at IBS and IBD patients in together, but there's quite a few that are, the majority I would say, are in IBD patients in particular. So in the microbiome area, the research studies that we're funding have to do with fecal transplantation, and Dr. Moayyedi will get into a little bit more detail of his particular study looking at fecal transplantation in patients with ulcerative colitis. There is another fecal transplantation study in Crohn's disease patients, also in pouchitis patients. We're also doing a fecal transplantation study in patients with IBS and major depression. In the diet area, we've got a number of studies looking at different types of diets for IBS patients and IBD patients, one in particular for pediatric IBD patients. On the mental health side, we have a number of projects also on the go. There is one looking at cognitive behavior therapy done online and seeing if that has an opportunity to improve outcomes in patients with IBD. There's a brain stimulation study in IBD out of Calgary that's going on, and one looking at oxygenation of the brain as a potential therapy for IBD patients. There's a few studies looking at yoga and meditation and how they can impact both IBD and IBS studies. Next slide. So on this side, you could see the different studies in the other thematic areas that I mentioned. So under patient engagement, we're looking at, what are people's attitudes and preferences towards fecal transplantation. We've also done a patient-led research study on how to improve recruitment and retention in clinical studies. A number of our patients that we trained through the PACER program out of University of Calgary led some projects as well, looking at what is the psychosocial relationship between food and IBD patients and what patient support tools would be helpful early in the diagnosis of their inflammatory bowel disease. And then there's another study looking at how to look at the impact that patient involvement in research has. Under the health services area, I did want to point out that we actually are collaborating with Crohn's and Colitis Canada. So CCC's contribution to the Imagine Network has been through its involvement and support of the PACE program. So I just wanted to highlight here in red, as you can see, these are all the very exciting PACE programs that Crohn's and Colitis Canada has supported. So I won't go into too much detail there, as I'm sure you would have heard it in other parts, but it's been a great collaboration. And then finally, on the sex and gender front, there's again a number of projects that we're funding in this area, really trying to understand the relationship between patient outcomes in different sex and gender, and patient and physician interactions, and how that could be affected by perceptions of gender. So again, we're very excited about the ongoing work that's going that we're supporting, and hopefully in the next year or two we'll be seeing a lot of results that are coming out of this particular network. Next slide. So I just wanted to mention before I pass it on to Dr. Moayyedi, we are at a phase where we're in the 4th year of the network, and it was originally set for 5 years, that we need to start thinking of potentially the next phase of this program. And so hopefully there's an opportunity for continued funding from the government, we'll be applying. And so we want to make sure that we are positioning the network in best way possible, and have sought as much input from the community about what's important in terms of research. So we've developed a survey. We actually have it posted up on our website. If you visit imaginespor.com, it's one of the sliders there. You will find a link to the survey, but we encourage you to please complete the survey. We're looking for about another 120 responses, so that we can really identify what are the priorities for the patient community. So that will help shape the research direction that the network takes moving forward. Great. So I think I'm going to pass it on to Dr. Moayyedi to talk about the MAGIC and the fecal transplantation studies. Thank you.
Thanks very much, Aida, and thanks to Crohn's and Colitis Canada for asking us to speak on Imagine. I just want to go over where we are with the research. As Aida said, there's a lot going on, so I can't possibly cover everything. So we'll just focus on the main study as well as the fecal transplant study. The other thing I would emphasize is that this is only possible because of the course of a CIHR grant, but they required matching funding, and Crohn's Colitis Canada were part of that match. So we're very grateful to them, because without this, none of this would be possible. Of course, by extension, it's all of you who contribute to Crohn's Colitis Canada who have made this possible. So thank you. So MAGIC, standing for Mind and Gut Interactions, the cohort study of the Imagine network. Next slide. So what this is a study going across Canada from Vancouver to St. John's, Newfoundland, where we're recruiting people with either IBD, irritable bowel syndrome, or healthy volunteers, and asking them to complete a questionnaire, as well as taking blood for inflammatory markers and genetics, as well as a stool sample for gut bacteria, and urine for what's called metabolomics, which is what both you and your bacteria produce. The chemical reactions that go on because of them are basically found in the urine. And interestingly, it's mainly from our bacteria in the terms of the number of reactions going on in our body. Next slide. So our aim is to compare gut bacteria and their metabolic profile in patients with Crohn's, ulcerative colitis, irritable bowel, and healthy controls. And in each of the disease type, our main comparison is with the healthy controls. And also we want to look at those who have active disease at the time versus those who have quiescent disease, so those with active ulcerative colitis, for example, versus those in whom the disease is in remission. Next slide. So we have published the protocol. Obviously, I've given you a very brief overview here, but the British Medical Journal Open published the actual full protocol of the study. Next slide. And so far, we have 16 sites that are actively recruiting. One, that's Sick Kids in Toronto, is still pending, but hopefully will start soon. And so far, we've recruited 4,677 people into this large cohort study, with over 18,500 biospecimens collected. Now, we aim to recruit 8,000, so we've still got some way to go. The issue is, of course, with COVID, our ability to recruit has slowed. It hasn't stopped, but obviously we can't, because of restrictions, we can't recruit as quickly as we have been doing, but hopefully that will change as things improve. Next slide. And these are just the centres involved. The ones in green are recruiting, as I said, from Vancouver to St. John's, Newfoundland. The one in yellow, Montreal, has actually just recruited its first 2 patients, and 6 kids, and the other yellow one in Toronto, we're still waiting. You can see we were recruiting quite well until this last year, where things have leveled off somewhat, although we still are recruiting, and hopefully we'll get back once this pandemic settles down. Next slide. This is just the various centres and how they're recruiting. McMaster's has recruited a total of 860, for example, but also Calgary, Winnipeg, Kingston, Edmonton have been great recruiters to this study. Next slide. So we want 2,000 in each group. And we are almost 60% there. We have nearly finished, rephrase that, we've met our target with Crohn's disease. We've still some way to go with ulcerative colitis. The big issue is we need more healthy volunteers, because we really need healthy people to compare for those with a disease, and we at the moment have 785 of those, and obviously we need quite a bit more. So anyone with friends or relatives who would volunteer to take part in the study, we'd really like to hear from you. Next slide. Just a breakdown of how we've recruited. More Crohn's and ulcerative colitis, which actually is in keeping with how the disease profile in Canada. There is slightly more Crohn's and ulcerative colitis. Next slide. And more women than men. There is a slight female preponderance in IBD, but not to the extent that we see here. And this probably more reflects that women are just more altruistic and generally nicer than men, which I think something I suspected for a long time, and this seems to suggest that this is what's happening. Next slide. But we do need to finish the study, get to the 8,000. We've got 2 years to do it in. So we really need everyone who hasn't taken part to take part if they possibly can, because this will provide us important information on how diet and gut bacteria influence and perhaps even cause these diseases. Next slide. So that's the study I've just gone over is basically looking at gut bacteria and diet in people with disease versus those without. And we've got a large data set, which hopefully will give us some important answers. But what we also need to do is intervene and change gut bacteria and see if that alters disease. And this is something that we have been doing. And we had been conducting a randomized controlled trial of fecal transplant therapy in patients with active ulcerative colitis, and randomize them to either have antibiotics before the fecal transplant or just have the fecal transplant, to see if giving antibiotics before the fecal transplant might be better at inducing remission in patients with ulcerative colitis. We didn't quite reach our target number, but we stopped early because of COVID, and analysis is still ongoing. Next slide. But to give you the context of this, we were the first to do a randomized controlled trial of fecal transplantation in ulcerative colitis, the first in the world. And this was published about 5 years ago now. made the front cover of our main GI journal, which is Gastroenterology. And so far it's been cited over 600 times, and it's still top 1% of citations of articles in its field. So it has been very influential and was funded by Crohn's Colitis Canada. Next slide. Sorry, next. It's had some Twitter activity here. This is mainly in Western nations, which is actually mainly where IBD is. Next slide. And overall, since we published our results, 3 other groups have published theirs. This is a systematic review by Neeraj Narula, where we collected the data from all of those studies. And the bottom line is there are now nearly 300 patients in randomized trials. And overall, roughly a quarter of people will go into remission on fecal transplant therapy after 6 to 8 weeks. And all of the trials show a similar result, which is what that figure is showing. Those blue dots are lining up. And I won't explain it any more than that, but basically it suggests that every study is saying the same sort of thing. So I think people didn't believe us at first, but now I think people are realizing that actually giving stool, we give it as an enema once per week, can induce remission in some patients with ulcerative colitis. Now, 25% doesn't seem that impressive, and indeed, it would be nice if it was a lot better than that. But actually, this is a reflection of all treatments in both ulcerative colitis and Crohn's disease. Next slide. So if you look at the fecal transplant trial that we published, we randomized people to either placebo or active fecal transplant therapy. As I said, we gave a enema once a week for 6 weeks. And then we did a flexible sigmoidoscopy, and people had active disease at the beginning. And we found that roughly 25% were in remission at week 7. This compared with 5% in the placebo group. Even with placebo, some people, just because of nature and time, will go into remission, but not many. Clearly a lot more in the fecal transplant group. Next slide. If you compare with Entyvio, this is a biologic therapy, which is probably the most effective medical therapy we have for ulcerative colitis. These are the same figures, again, about a 5% placebo response rate, and a 17% went into remission at week 6 with Entyvio. Now, I wouldn't want to say these are equivalent or that everyone should be having fecal transplants. The thing to emphasize is in the Entyvio arm, in the Entyvio trial, there were 374 patients involved in this compared with 75 described in the fecal transplant trial. And we really need a lot more patients before we can be sure whether this treatment works or not. And we need to understand better why it works. But nevertheless, people that say, well, it's not that impressive are right, but it's actually just as impressive as anything else we have in this area. Next slide. So with that in mind, as I said, we decided to do another randomized trial to see if we could make things better with antimicrobials for 2 weeks prior to the fecal transplant. And we actually saw if maybe if we gave it twice a week for 8 weeks rather than 6, whether that would do any better at inducing remission. Next slide. Now, we're still analyzing that data. As I said, we closed it early, so we recruited 65 patients, and thank you to those who took part in this study. essentially we had to stop because most clinical studies that weren't COVID related were stopped due to the pandemic. What we find is that if we don't look at them in randomization, but just look overall, roughly 20% are in remission, 21% are in remission by week 8. This tells us a number of things. First of all, although we haven't analyzed by antibiotic versus no antibiotic, no real sense, it's roughly the same as the first trial I presented. So I don't think there is any benefit to antibiotics, although we've yet to actually analyze that specifically, nor does there seem to be any benefit of extending it to twice weekly for 8 weeks. Again, the remission rates seem the same as once a week for 6 weeks. And 20% or 21% is very strict criteria of remission with everything normal, person feeling absolutely fine. Over a third had a Mayo of less than 4, which actually most people would call remission. So if you soften the definition of what remission is, things get even better. Next slide. And just a picture is worth 1,000 words. So just in this last trial that I talked about, just to give you an example of what happens, here's a 29-year-old man who's had ulcerative colitis for 17 years, failed steroids, failed azathioprine because he got acute pancreatitis, which is an occasional side effect of that drug, wasn't keen on biologics, and for the last 2 years had refused any other treatment, and his colon looked pretty bad. This is not the worst I've ever seen, but most gastroenterologists would say that this red and inflamed area is quite bad inflammation in the colon. Next slide. And after 8 weeks of therapy, the colon essentially looked normal. Now, we had identified a donor that seemed to work very well. COVID and other things have meant that that person is no longer donating. So we actually need more donors so that we can continue giving healthy stool to patients with ulcerative colitis. So if you are interested in doing that, obviously anyone with inflammatory bowel disease, I'm sorry, but we don't want your stool for treatment because obviously you have a disease. But if you know someone who's healthy, who's willing to donate it, preferably on a weekly basis, then we would be delighted to hear from them. We would, of course, test the stool for all known diseases, and the person has to be healthy. That's the other thing to emphasize here. But if anyone fits that criteria, as I say, we would love to hear from them. Next slide. This is just thanking everyone who's made this study possible, particularly Crohn's Colitis Canada, but also, of course, CIHR, who have given $12.5 million to this project, and a variety of other sources of funding, for all of which we're very grateful for. Next slide. And this is just our contact details. So, by all means, follow us on Twitter, Facebook, or visit our web page that's outlined here. And with that, I'd like to thank you and happy to answer any questions.
This was great. Thank you so much, Dr. Moayyedi. And now we advanced to the Q&A period. For this part, what we've done, as Sarah mentioned at the beginning of our session, is that we've compiled a list of commonly asked questions that the registrants have put in during their registration. But I see that we received a lot of live questions as well. So I'll do my best to cover a combination of the live and the ones that have been submitted during registration. Now, having said that, thinking about some of the questions that we come into a CCC, Crohn's and Colitis Canada, specifically about certain studies, recruitment, and so forth, I thought I would start there before we jump into the questions that have been submitted by the registrants. This would be for you, Aida. Wondering, so it looks like recruitment has stopped for a lot of these studies. For the MAGIC study, it looks like there's still recruitment going on. If there is someone in the audience who's interested in participating and they don't quite know where to go for that kind of information, how would they go about finding out where they would have to go to participate?
Sure. I mean, so the obvious thing is just check out our website at imaginespor.com. On our website, we do have tabs there where you're able to, find your recruitment site that's closest to you. As Paul mentioned, there's 16 active sites across the country. So, there'll be contact details for each of those sites. But also you could just, send us an email. There is, again, a link on our website with basically my email address, and I will happily connect you to your closest recruitment center.
Great. On a continuation of that question, we do have some non-Canadian audience members, a lot from the States who join us. Notice that for one of those, wondering whether this is, can patients who are, or healthy individuals who are joining us from outside of Canada, is there a way for them to participate in your studies?
Yeah, that's a great question. I do get that often as well. So, it is a challenge. I know, we do require patients to come in annually. Sometimes, especially at the beginning, we would give them their specimen collection samples and then ask them to return it the following week. Even though we only collect samples, once a year for 4 years, it does require an in-person visit. And, we do need to check health records. So it is intended for a Canadian cohort of subjects. So it just would be really challenging for patients outside of the country to make those visits and have all the medical health information accessible to our recruitment centers.
Okay, thank you, Aida. Dr. Moayyedi, a question for you. It's about the fecal FMT trial. You mentioned that about 25%, that seems to be the magic number. So 1/4 of those who participate in the study tend to go into remission. Have you identified anything unique about that 25%? Any kind of hypothesis around that? Why is it that 1/4 of the participants consistently go into remission and 3/4 don't?
Yeah, so it's a great question and something we are very interested in doing. And actually, that's why we have that large study as well. The trouble is you have more bacteria in your gut than there are stars in this galaxy. And so it's very difficult with 75 patients to make any sense of what the data are really telling us. Although we can still try. That was why we had that second trial, not based on hard evidence, but a sort of suggestion of where the data might be going, but clearly that wasn't correct. But we are still looking at particularly gut bacteria and what might predict success or failure of the therapy. And this is led by Dr. Mike Surrett, McMaster, and we are finding some interesting signals of particularly of bacteria that are present in people or present in the donor that seem to predict success. And so we will try and both select donors that fulfill that sort of criteria, but also keep on collecting more data so we get more understanding. Another thing, if we just look at patient factors, one thing that seemed to be the case in our first trial was that those that had the disease for just a short period of time before they got their fecal transplant seemed to do better. There was more remission in that group, although there were very small numbers like that. Others have not repeated that finding, so that may just be a play of chance. After all, only 4 people got fecal transplants who had had the disease for less than a year. So it was always very difficult, based on those small numbers, to be sure of anything. But yeah, I think the key thing is to look, what is it about the donor and the recipient that makes it a success? What I would also sort of emphasize is that 25% is remission at 6 weeks, same with Entyvio. If you carry on Entyvio for longer, you get more in remission, and it's the same is true of fecal transplant. So what I tell patients in general is that roughly a quarter will go into remission by week 6. Another quarter will improve significantly, and we carry on the fecal transplant in that group, and often but not always they will go into remission. And another 50% it isn't really working, and we just stop.
Great, thank you. So you're almost done the FMT trial. And then there's the dissemination part. Thinking about the audience in terms of the folks who have UC, are looking for alternatives to drugs and so forth. Can you, this might be a difficult question to answer, but can you give us some sort of idea as to when this could be part of the standard practice that's offered to UC patients as an alternative to therapies such as biologics or whatever else that the gastroenterologist has prescribed for the UC person?
Yeah, I think that's going to be hard to predict. But what I would say is that Aida is applying to Health Canada for our next study, looking at new donors as to, as we were saying before, what predicts success. Once we have what we feel are good donors, we will then hopefully do a randomized trial through the Imagine network across Canada, so that most people in the future will have access to this treatment. And obviously the screening of donors will be rigorous, and we'll make sure that they work before we take part in the study. But in this way, although it will be in the context of a study, most people in Canada should be able to get this in the future. When, I'm not so sure. I hope next year, but obviously a lot depends on COVID as to whether this will be possible.
Well, that's encouraging. I'm sure our audience members are very excited to hear that, because we do get a lot of emails and questions about FMT as an alternative. Aida, just following on the idea, I know there is a request for healthy donors. So how can you just describe again, let's say I live in a remote area and I want to become a healthy donor. Can you explain as to what does that entail? Can I mail in my stool samples? How does this work?
Yeah, I mean, if you live in remote areas, it certainly makes it a larger challenge for us. It needs certain conditions to, properly transport the stool, and it has to be frozen by the time it gets to our lab. So yeah, I mean, in a couple of different ways, we're looking for healthy donors, just part of our MAGIC study, where people again would complete online surveys once a year, provide their urine, blood, and stool, and just be seen by the recruitment centers once a year. Again, that would have to be in some close proximity to one of our centers. That's why we have so many centers across the country to try to reach out to as many people. Again, some people do travel to come into their IBD clinic already, and hopefully if they're coming with some family members, that's a way we're hoping to get some healthy donors. For the overall, for the FMT studies for stools, that's being run out of McMaster. And so again, it's a much more significant commitment in terms of providing stool, perhaps on a weekly basis. And so proximity to McMaster, would be a priority. I think, there might be ways we can try to, if we can get it in same day delivery type thing, or within a couple of hours, that, might be manageable, but it does require some closer proximity to McMaster for the fecal transplantation healthy donors.
Okay, thank you. What about relatives? So, the majority of our audience members are somehow part of the IBD community. They may be relatives or friends, or because there might be some genetic link to IBD, do you accept relatives as healthy donors?
We do, Kate. Yes. And we are recording if they're, we ask them as part of the surveys if they have a close relationship, if they're related to somebody with IBD or IBS. So we are accepting them as healthy donors, and, we will track and know if they have a close relationship as well. But so long as they don't have any GI health issues, or, don't have any, let's say, cancer that, can impact them and, survival rates within the next 5 years, we would accept them as a healthy donor. So that has been our primary approach to recruiting healthy donors for the MAGIC study, is to reach out to, parents, siblings, children of people with IBD or IBS. So yes, we'd gladly accept them.
I think that's good news for our audience members. Dr. Moayyedi, let's move on to the first question. So the first question that was submitted frequently by our registrants is it common to have both IBD and IBS?
Yes, it is. It is a question I'm often asked, and it is common for people who have IBD but are in remission to have actually fairly similar symptoms to what they had when they had IBD. We don't know why, but IBD sufferers are much more likely to have IBS, even when their colon or GI tract looks normal, compared to just the general population. We believe it relates to the gut bacteria, as we were saying, and also possibly microscopic inflammation. There is some evidence that those with IBS, everything looks normal, but there is subtle inflammatory process going on. And of course, even when you're in remission with IBD, there are subtle signs of inflammation, and maybe that's why some people still have symptoms.
So as a follow-up question then, people who have IBS, my understanding is there's a large percentage of Canadians who have IBS, both the IBS-D and IBS-C. If they have that for a long time, could that lead to, is that a risk factor to developing IBD? No,
interestingly. So yes, whilst people with IBD are more likely to suffer with IBS, those with IBS are no more likely than the general population to go on to get IBD. I mean, obviously, there's millions of people in Canada, a few will, but no more than people who have otherwise been healthy and then suddenly get, sadly, Crohn's or colitis. So it's an interesting thing, and part of the MAGIC studies to try and unravel this.
That's great. We can hardly wait. We'll have to invite you again, you and Aida, to when you have more data with the MAGIC study to update the audience on what your findings are, in particular on mental health. I know that's a huge concern for the IBD population. The next question is, are there specific types of diets such as the FODMAP diet that are known to promote a healthy gut microbiome that is safe to use in people with IBD?
So I'll answer this one. Yeah, the low FODMAP diet, but which is basically an acronym for a diet that is low in fermentable food products. All food ferments, but some ferments a lot more than others. That's primarily used in irritable bowel syndrome. It's a diet developed in Melbourne, Australia, and by a dietitian, Susan Shepherd, and there is evidence it works in IBS. There have been studies in IBD, but what I would say is, first of all, it's not that clear, although it may help some people, but it doesn't promote a healthy gut microbiome. It's actually the opposite. It might help symptoms, but if anything, for what we know of the gut bacteria, it actually promotes an unhealthy gut bacteria. So it's okay in the short term to try and help you with symptoms, but this isn't an answer for the long term. As you might expect, really, the reason things ferment is because of gut bacteria, and you actually want to promote good bacteria in your gut, which also ferment food. So a nuclear option of depriving a lot of gut bacteria of the food they eat may not be as good in the long term as you think, but in the short term it can be helpful.
So that is a conundrum then, in some sense, because I do believe there are some IBD patients who really feel that the FODMAP diet supports them quite a bit. So I'm wondering, I mean, this is a perfect segue into the next question, which is, what about probiotics then? Could that be counteracted by taking daily probiotics to promote healthy gut bacteria?
So that again works in IBS, just as the low FODMAP diet does. It doesn't work, as far as we can tell, that well in IBD. It doesn't mean it doesn't work, but the trials that have been done to date have been disappointing. So that isn't to say the approach isn't sensible. I believe it is. It's just we don't understand enough about the gut bacteria to give the right bacteria to people with Crohn's and ulcerative colitis. FMT is just a dirty probiotic, really, but because there's so many bacteria there, we obviously get it right occasionally and give them the right bacteria. But when you do it in individual strains, as you usually do with probiotics, or even 10 or 12 of them, you may not get the right ones. Now, the caveat is, recently there's been a study that suggests maybe a new cocktail of probiotics, if you like, derived from fecal transplants, might be beneficial in ulcerative colitis. I think more data are needed, and no, you cannot get this outside of a study as yet. And indeed, that's where we're going as well. We're just trying to get at what gut bacteria we need to give to people to make them healthy. But, the standard probiotics you get over the counter at the moment, I would say there's not good evidence they work in either Crohn's or ulcerative colitis. If you happen to have IBS as well, they may be helpful in that regard, and that's the same with the low FODMAP diet. But to truly treat your Crohn's or your ulcerative colitis, there's not enough evidence that it does that as yet.
So then I suppose amongst your patients, when they come to you about probiotics, there isn't one particular brand or type that you would recommend because of the lack of evidence? No,
so not at all for, as I say, inflammatory bowel disease. For pouchitis, they can be effective given rectally. Dr. Narula is doing a study in fecal transplants for pouchitis, and anyone who has this, I would recommend, if they've got active disease, to get in touch. But there also probiotics can be helpful. There's some evidence that a cocktail of probiotics called VSL might be helpful for that group. But in general, no.
Okay, and VSL, that's not available yet?
No, VSL is available in Canada, and it's not called that though anymore. I'm blanking on the name, so not very helpful in this setting.
Is that through prescription only, or is that an
No,
over the?
you can get it there. It's expensive. That's the only problem. But you can get it in this country, I think.
Okay, great. I'm going to switch gears. The next question is about mental health. And I know we have an expert in the audience as well on this. Can depression and/or anxiety trigger inflammation or a flare-up to occur in people with IBD? And then there's a second question to that. Can antidepressants or anti-anxiety medications be used to help manage Crohn's or colitis?
So the answer to the first question is yes. That was from work done by Charles Bernstein and his colleagues in Winnipeg. Just to be clear, neither anxiety or depression cause Crohn's or ulcerative colitis, they just don't. But if you have it, then sometimes depression or anxiety may trigger inflammation. And the opposite is also true. If you have a flare-up of your disease, that can make you anxious or depressed. But I would emphasize that these associations are modest, and there are people that go through amazing life events with a lot of anxiety or depression and actually don't get a flare-up of disease, and of course people who feel fine mentally who do. So it's not like it is the cause, but on average you're more likely to have a flare-up if you have a mental health issue. And there's lots of biological evidence as to why this may be. Your brain has a profound effect on your body and can both suppress and induce inflammation. Now, it's a great question as whether antidepressants could help Crohn's or ulcerative colitis. We actually wanted to do a randomized trial on this, but unfortunately the psychiatrist who was doing this moved to Australia. And we haven't really got that off the ground. Others have looked at this as well, but it's only been in small studies so far. It would mainly be the antidepressants though. Anti-anxiety medication probably doesn't have any effect because those drugs tend to work just on the brain. Antidepressants, actually, the receptors they work on are often even more prevalent in the gut than they are in the brain. So there's quite a lot of animal data and just what we understand of how these drugs work that might suggest it could have some effect, although it's unlikely to be dramatic.
Fascinating. Okay, next question. It's about diet again. Can certain diets help manage both mental health issues and IBD symptoms? I guess that's along the lines of the microbiome.
Yeah, so I think the honest answer to that is we don't know. We certainly are interested in the diet, and Dr. Narula, again, I mentioned it before, is interested in a particular diet that he's developed for Crohn's disease. But as yet, there is no good evidence that diets help people with Crohn's or ulcerative colitis. That isn't to say it's a waste of time, it's just we haven't studied it well. But certainly from my clinical experience, I certainly see certain patients who swear by a certain diet that really helps them. But a different patient will have a different diet that really helps them. And it's difficult as a clinician to make sense of all of this as yet. But hopefully the MAGIC study will at least get us started in this area. And the mental health issues, yes, our gut bacteria are work done at McMaster and elsewhere has shown that our gut bacteria do influence our mood. And our diet shapes our gut bacteria. So it's quite likely that diets will help mental health issues, but again, no evidence as yet as to exactly what to do, unfortunately.
So just as a continuation of that, I know there's a lot of studies that they're out there on Mediterranean diet. in general. So you said there's really no studies out there. Any kind of hypothesis on that, why you think that may be supportive of IBD and symptoms and perhaps even mental health?
Yeah, I think as you mentioned, Dean Tripp is in the audience. He's a psychologist from Queen's who's leading the mental health aspects of Imagine. So this is something we will study, but as yet, I don't think we have good information in IBD as to what might be beneficial. I think a Mediterranean diet is a good idea. It probably is a healthy diet for your heart, just general well-being. So I'm certainly in favor of you trying that, but it's not, in terms of hard evidence that this will work, we don't have it. And the trouble with hypotheses is you can make a hypothesis if it's anything. I like evidence to show that it actually works. And as yet, we don't have that for people.
Okay, thank you. The next question, how does having an ileostomy or J pouch impact the gut microbiome, or does gut-brain connection differ in people that have had an ostomy compared to those with IBD that have not had an ostomy?
Yeah, again, that hasn't been well studied, and we should do it, given that we feel that it's important for mental health, your gut bacteria. Your gut microbiome does change significantly, of course, if your colon is removed, and a new colon, if you like, fashioned out of your small bowel, which is what a J pouch is. So the gut bacteria do differ, particularly initially. Over time, they do become a bit more colonic. I think the biggest way to emphasize this is the main bacteria in your colon like to have no oxygen. They're called anaerobic. The higher up in the gut you go, the more aerobic bacteria that actually like oxygen are there. And if you like, there's a shift towards more small bowel bacteria, as you might expect in people who've had an ostomy and J pouch. But over time, it becomes more colonic.
Okay. Okay, next question is about biologicals and biosimilars. Do those medications affect the gut microbiome? Have there been any studies out there that show whether there's any changes? They've been very effective in supporting patients with IBD.
Yeah, not much data there. This is again something that we want to study because it just hasn't been. That's not to say that drug companies aren't interested in that and are looking at, but as yet, again, no data that I can tell you that says, oh, if you have this profile in your gut, then you're more likely to respond to this biologic or that. But again, with MAGIC, this is why we're following people up over time. We'll see who does well, who doesn't, who's on a biologic, who isn't, and what their gut bacteria looks like, as well as their genetics and their diet. So hopefully we will have some answer to that very excellent question in the future. But again, as of today, no insight I can give you, I'm afraid.
Thank you. So I'm going to move on to the next question. I know your trial, FMT trial, is closing, but you did talk about a larger study. So can you speak a little bit about the eligibility of people who might be interested in an FMT trial?
Yeah, so we've made our criteria broad, and we hope to start another one if Health Canada allows us, even during COVID, but only at McMaster. So for people in the Greater Toronto area, I'm afraid. But that could happen later this year. We do make it very broad. So it's basically anyone with active disease. If you're in remission, unfortunately, although it's important to know how fecal transplants help that, the studies have to be too large, and we're not drug companies, so we just can't afford to do those sorts of studies. But we need smaller numbers for those with active disease to show benefits. So we need you to be in a flare. We need you to be on stable medications. So you've been taking, in the case of biologic, you've been taking that biologic for at least 3 months, for steroids at least a month. But if you've still got active disease despite stable medications, then you'd be eligible to take part in the study. And there are no real exclusion apart from the J pouch, which you mentioned before, but we have another trial for people with pouchitis. Also, if you're hospitalized, we just feel this is too experimental at this stage if you're that ill. So that is another exclusion criteria. There are others, but generally people are eligible as long as they're on stable medications.
Okay, perfect. Thank you. We have a number of other questions that we have on our slides, but unfortunately, I just looked at the time. I see it's 13 minutes after 8. We're supposed to be concluding the session at 8:15. Wish we could talk a little bit more, but I want to be respectful of the time that we had told our audience members. So with that, I'm going to close the session. I would really like to sincerely thank Dr. Moayyedi and Aida for joining us tonight and updating the audience on a very important initiative, which CCC is so proud of partnering. I see it's a holistic approach, and there's so many studies that you've gone over and really speaks to how IBD is complex. And we hope that, I mean, CCC is here to support you and for the next round. So we hope to continue to hear about the success of Imagine SPOR network. And so with that as well, I'd like to thank the audience for spending your evenings with us. When you sign off from the webinar, a very short survey will pop up. It should take seconds, literally seconds. I've done it myself to fill up the survey, so please do so. We do take your feedback seriously, and this is how we continue to improve our webinars and also to come up with topics for the future sessions. We also would like to thank BG Communications, who has been offering free live French translations for our webinars since the beginning of this year. In particular, Mike, whom you're hearing if you're on the French channel right now. He is the gentleman who's been translating for us. Thank you so much, Mike, for spending many hours with us, almost every few weeks. And last, we are on social media. Our handle is at Get Gutsy Canada. If you're not connected already, it's another great way to receive bite-sized updates on Crohn's and colitis. And with that, I want to thank everyone again and enjoy your evening.
Thank you.
Thank you.